Good afternoon. Thank you for coming to the second session. We had a lot of spark the first time, so hopefully we'll continue on that. So first and foremost, in talking about this, I've talked a lot about some of the things that we've been discussing throughout the day. So basically, it's not all about the science that impacts our health. Social factors have a great impact on our health as well. Where we live, where we play, our health environment, our environment plays a large role in our health. So leading into that is the Commission for Health Advocacy and Equity in Rhode Island. The whole goal and focus of that is to address social determinants of health. So to give you some background on the commission, it was introduced and written into legislation in 2011 with support from state legislators. The intent of this commission is to eliminate health disparities in Rhode Island. The commission works directly with the Director of Health and public health officials to create policies aimed at addressing the social determinants of health in order to achieve health equity in communities throughout the state. The purpose of the commission is to advocate for the integration of all relevant activities of the state to achieve equity, provide direct services, again, to the Director of Health, and indirect advisement to the department's senior administrators and planners through the Director regarding issues of racial, ethnic, cultural, and socioeconomic health disparities. Also is to set goals for health equity and preparing plans in Rhode Island to achieve health equity in alignment with other statewide planning agencies and address disparities in health status. So some of the common definitions that I know have been utilized throughout the day, but it doesn't hurt to go over them one more time. But what is health equity? Health equity means attaining the highest level of health for all people and valuing everyone equally. To achieve health equity, efforts must be made to address avoidable inequalities and injustices. What are health disparities? Again, the differences in health between population groups. Disparities include inequalities in the rates and severity of diseases and other adverse health conditions. So in doing the report, which is available online, we do have it. This was the first report that we put out, our legislative report. And what we have, we're just going to go over synopsis basically of the findings that we found of chronic ailments that were definitely impacted by health disparities in the state of Rhode Island. So we have maternal and child health. So the findings are that the infant mortality rate for Black infants is almost twice that of white infants. Publicly insured teenagers have more than twice the percentage of unintended pregnancy compared to those with private insurance. This obviously was discussed earlier, but just to really kind of hone in on the publicly insured teenagers. We still have situations going on today right now with the Affordable Care Act where public insurance, people with public insurance are still treated differently in the healthcare system based on these insurance carriers. Some of the recommendations that we have is the key risk factors for intervention identified in the Rhode Island Infant Mortality Team Strategic Plan, and that should be implemented. You can find that strategic plan online as well. One of the things that's really important with the maternal and child health is that infant mortality is related to the mother's health, public health, and socioeconomic conditions. So as we, might be getting, prenatal care and getting ourselves taken care of with hospitals and doctors, etc., we're still going back into that same environment. And once we're going back into that same environment, those health ailments are still going to persist. So as we have the hospital, and the doctor's appointments, there's still a whole other health aspect that's impacting individuals' health, pregnancy, maternal, etc. So that's something that I really want to kind of hone in on as we continue this discussion. So with asthma, the findings with relevant core cities, Providence, Pawtucket, Central Falls, and Woonsocket have the highest percentages of children who visit the hospital or doctor for asthma. So one of the common themes that we're going to see again is adults who earn less than $25,000 per year have a significantly higher asthma prevalence than those who earn more money. So one of the things that we can discuss with that is When we see the earning potential of the individuals that these chronic ailments are affecting and impacting greatly, there is an income. There is definitely a correlation between our wealth and health of our Rhode Islanders. Recommendations that we have set forth are for schools to be healthy environments, the financing problems for necessary school facilities. I don't have to go into all of that, but one of the great things is Governor Raimondo spoke about this issue in the state address. So this is something that is being tackled, being discussed, because one of the important things is, as we know, in the core cities, they are the oldest schools. We know that in the core cities, in the oldest schools, we're going to have more mold, we're going to have more rodents and things like that, which definitely impact the health of our children in the core cities. So really want to kind of think about that, because most of our children spend most of the time, besides home, in the school, after school activities and things like that. So those things really need to be taken care of. And they need to be taken care of in order of, where the schools are, and the schools with the worst, structure, facilities, and things like that. And like I said, again, that's where we're going to find the schools in our core cities. So some more continued recommendations is the statewide Healthy Food Financing Initiative. This too should be implemented to provide grants and loans to retailers that improve access to healthier food. So, for example, a lot of our corner stores and convenience stores, bodegas, whatever you may refer to them as, make most of their money out of off of cigarettes and a lot of very, very high-priced items that would be obviously a lot cheaper than other stores, etc. So supporting these stores, supporting these smaller businesses with loans and grants to improve this will help support overall policies and things like that, so we can kind of have more sustainability and making sure that the neighborhoods that might be considered food deserts also have access to this healthy food with, in fact, if we're able to implement this initiative. So as we go through diabetes and heart disease, which I see that I'm really going good on time this time, because last time it flew by. So as we have the findings with this is, again, adults who earn less than $25,000 per year have significantly higher disease prevalence than those who earn more money. This is the same with those who have reported disabilities. So again, we're seeing the same findings with our socioeconomic status and our education directly impacting our health. So our recommendations are for insurers to include evidence-based programs as part of their benefit package to improve adoption of healthy behaviors. A lot of times when we are dealing with our insurance companies, we're dealing with them at the end, when we need insurance, when we already have the problem. So it's kind of trying to move it towards prevention, moving it towards primary prevention. What can insurance companies do? And as we collaborate with insurance companies, really have them focusing on keeping us healthy, as opposed to just waiting until we get sick and then investing. Because we understand and know that chronic ailments and after the fact, with diseases, it's a lot more expensive than the cost in the system. So oral health, again, adults without a high school diploma are much less likely to have seen an oral health care provider in the past year than those with a diploma or even more education. I think in our first morning keynote session, he was saying, just one more year more of high school or college, 1 year of college, 1 more year more, dramatically increased people's lifestyles, livings, healthy behaviors. They didn't smoke. Just everything was dramatically increased just by adding 1 more year of education. So in recommendations for that, to decrease the disparities is to have an executive order requesting that the Rhode Island Executive Office of Health and Human Services implement a managed care model. This is identified in an assessment of Rhode Island Adult Medicaid Adult Dental Program, and it was prepared in 2014. So it's something we are looking to, partner up with to kind of see how we can work together and bring a lot of the work that they've done and we've done to fruition. So in regards to obesity, we know that obesity is definitely a wide range. It's impacted many, many people. But one of the things that we didn't know and that we found in our data was that male adolescents compared to female adolescents who have other than a heterosexual orientation and adults with disabilities compared to those who do not have disabilities have, again, a significantly higher obesity prevalence. So we all know that there's definitely issues of obesity based on race and ethnicity, culture, and socioeconomic status. What we didn't know was, sexual orientation as also being a key factor. So recommendations that we have for this is to increase the likelihood that school-age children become obese is to increase the number, obviously, of physical education. So, and this is something that's not impossible. Cumberland Public School Department has already done this. They have increased the amount of full-time physical education teachers, and they have also gained another person who is also physical education that specifically focuses on children with disabilities. So seeing that we know that children with disabilities and having more phys ed, is an issue, it has been addressed. So it is something that we can streamline through, we're out in schools because we work in silos sometimes. And if something's working, and we know it's working, then we need to all adapt that and work that into ours as well. So I'm not going to go much into the visual recommendations. These are things that you're going to be addressed by one of my colleagues on health and all policies. But I do want to add the, healthcare systems. My apologies. Okay, so in regards to healthcare systems, well, the question is, what steps can healthcare systems make in addressing the social factors? So we know that what we can do as a community, we know what we can learn as a community, we know the work that the commission's doing, we have community health teams that they're going to discuss further, but healthcare systems nationwide all have a role in impacting our social factors. So collaborating with community partners and community gardening. As I had mentioned earlier, we are trying to work with the community gardeners with over in the Prairie Avenue area where our new site is. So that's the hospital trying to invest the time into the community. And as was discussed earlier, was obviously medicine and things like that kind of have a bad rap in some situations in terms of the whole mistrust of the medical system. We really need to strategically utilize our partners and gaining that trust and working with them closely, because a lot of times when you're within the hospital walls, it's really the community that is the key stakeholders and really who to talk to and do that. So it's really utilizing our strategic partners as advantageously as possible. Another thing is we have the foster program, over at Hasbro Hospital. And this is specifically for, foster youth. And the importance of this is that it offers stability. So we are aware of the fact that foster homes and foster children are not getting a continuity of health based on being in different places at different times. So this is a situation where a hospital has created an environment where foster kids or youth, children, can get that continuity of care. And that's really, really important to make sure that we're really reaching many aspects, reaching out into the community to really see what we can do. Because there's a lot hospitals can do in healthcare systems, but it also we want more community members to be involved with that as well. One other thing is information technology. There have been studies shown, and I have another report on that. If you want understanding the impact of health, IT in underserved communities with the electronic medical records. So there's a lot of things that have been done. There's also a lot of things that are currently being done, and if you're interested in getting more involved with the Health Equity Commission, we have our contact information. Health has made it easy. Everything's online, everything and things like that. So if you're interested, we're more than happy to answer any questions and discuss that with you further. Thank you kindly.
So the commission has really kind of set us up with some very good ideas and information to lay out, what we're doing with health systems. So the next group will be the community health team, and this is an exciting group in that the community health team is part of our health equity zones, the one that's speaking today from South County. And there will be 3 speakers to talk about what they're doing and how that is kind of setting the stage for working in healthcare and with disparities. Elizabeth Fortin is a community health team manager at South County Hospital Healthcare System. I've known her forever, and we work together forever. We also have with her Cassandra Stukus, who is the South County Hospital Community Health Team member, and she's a behavioral health care manager. And then we have
Toni Schlais.
Yes, I have problems with Schlais. Thank you. She's the nurse care manager at Wood River and Health Services, and is part of the community health team. So take it away, Liz.
Good afternoon, folks. Try to keep you all awake. I'll try to stay awake too. So it's kind of interesting to do the same kind of presentation once in the morning, once in the afternoon. I have no idea if it would sing. Here it goes. So the community health team, there was an interesting comment this morning, and I just want to make sure that you're all aware that this is a pilot project. And I'm going to talk with you about the funding through the Care Transformation Collaborative of Rhode Island, which basically gets its funding from the health plans. And that's really important to know, because I think some folks said, well, you know, like something to the effect of why an N of 1, which we're not an N of 1, but we're really quite small. It's to test the feasibility of this, and then to be able to ramp it up. And we are going to be very ready to ramp it up when more funding is available. So the South County Community Health Team, today our goals are to kind of tell you a little bit about the model and the mission, and how the team-based approach helps to reduce disparities and promote health equity. And we're also going to describe some findings related to social, behavioral health, and economic barriers to health through a patient story. And my colleagues, Cassandra and Toni, are going to tell you that story. And then identify some of the implementation successes and challenges. We've been in operation since September, so really a short amount of time. So the Care Transformation Collaborative, for folks that don't know, there's a whole website on them, is an opportunity that's funded through the Office of the Healthcare Commissioner to help support primary care practices in Rhode Island. And the funding comes directly from the health plans. And so this community health team was funded. There's 2 pilots, one in the south, one in the north area of the state. And we were kind of, the team sort of model is a lot like Vermont's Blueprint for Health. Basically because the community health team sits outside of the primary care office practice. So we are based in the hospital. South County Hospital just happens to be our home. And we are deployed out into the community. And we work directly with the practices who refer to us. And the areas of focus for this particular community health team came from the health needs assessment that was conducted statewide, community health assessment, and in 2013. And the areas in the south that really were in need from a disparities perspective with mental health and substance abuse treatment. A lot of folks who are disabled down there and need resource. Or suffering and need resource, and maybe not necessarily disabled, but also diabetes and heart disease. So what ended up happening is that as this project got underway, through this funding, the goal was to try to focus on those particular core group of patients or individuals in the community. Actually, this is for adults. So we received 1 year of funding, and we just received notice that we will get an additional year, so we'll be in operation at least through June of 2016. Our goal is to try to improve the healthcare and demonstrate directional improvement in the total cost of care. Challenge number 1, by focused on identified high-risk and high-cost patients. And those patients are actually identified by the health plan, so it's very funneled kind of referral pool. And we're doing the work by trying to reduce the disparities for these vulnerable individuals. So the core team is community resource specialists. Rhode Island Parent Information Network contracts with us for those 2 workers. And I have to say, Margot Pyers, line reading in the back row, is one of our community resource specialists. She's doing a terrific job. And community resource specialist is pretty much a community health worker. And we also have, so we have 2 of those, and they're doing a lot of outreach, screening, support, trying to identify community resources and hook people up. They know stuff that you can't even imagine about how to get people help. It's just incredible. I can't even figure out how they know all this stuff. And then we also have a behavioral health care manager, Cassandra Stukus, who we're lucky enough to have funded through the Rhode Island Foundation for this project. And she does behavioral health assessment, crisis intervention, skills building, referrals, and care coordination, basically for behavioral health primarily. And she also does a lot of work directly with the patients, you know, with skills building.
So the practices that we're approved to work with are listed here. They're all primary care practices in the South County area. And our team is basically what I described before, plus an analyst, Gail Meisner, who has helped us to build a patient registry. And we're collecting data and able to produce reports back out for the practices and things on their patients. And we're housed at the hospital, and so we're co-located there, and we have the resource of the hospital for nutrition, for additional behavioral health, for pharmacy, and any other kind of disease management kind of programming that might come out of the hospital, including, I think there's some of your Department of Health programs out of the hospital as well. So, so a little bit about the target population, and I'm just going to try to race through some of this so we can tell our story. So we basically, the health plans supplied all these lists to the practices. The practices identified patients off these lists that they thought could benefit from our services. They referred them to us. I compiled everything, sent it back in. By the time we were all done, we had like about 145 people who were eligible. We have plenty more. We're probably up over 235 that have been referred to us by the practices. But this intervention group is what's going to sort of demonstrate our effectiveness from a total cost of care perspective. And the reason why it ended up so many less than who we originally referred is because so many people's insurance has changed from the beginning of the identification to the point at which the health plan sort of said, here's your group. And so that's a challenge in and of itself. People's insurances just keep changing. And it's tough on them, and they don't exactly know what to do all the time. So that's a core area that they help them with. Out of all of the people that we've been referred, this is sort of the smattering of the ages of who's referred, and the actual active people in the program sort of is very, very similar to this. So what are we doing? A lot of the interventions that I mentioned before: outreach, screening, assessment, referral, trying to identify social and behavioral health barriers, doing a lot of high touch in the community, and working with the nurse care managers that are in the practices. And I want to give you a little bit of data. So a lot of what we've done is to go to the PCP office, meet with the nurse care managers, do case reviews, try to figure out how to connect with that patient in a warm handoff. We're also working in the community with like the Basic Needs Network, Washington County Care Transitions Collaborative, and a host of other entities, trying to do case collaboration with South Shore Center, who has a health home. And as I mentioned, we do visits, home, community, office, and there's been a lot of development work just to get going. But I think we've sort of hit our stride at this point, and our numbers are growing of the people who we are actually successfully working with. So when the community resource specialists meet them, they do this member health survey, and I've got some of the data here. So what they identify as some of their core issues is true to form with what we would expect. 63% of them describe themselves as having some type of depression, and 31% some type of a mental health issue. And 48% of them so far have identified a chronic pain issue. I can't tell you how discouraging it is for folks. They apply for disability, they get denied, and we're doing a lot of work to try to help people to at least get reviewed again, get their information together. Many of these folks don't even have a source of income for the most part, which is really quite difficult. They might have insurance, but they don't have any way to get around. It's quite difficult for them. And some of the barriers that they report, number one, transportation, 37% of them. Housing, 23%. So even though you're in South County, there are folks who can't find places to live that are affordable for them. And it's a challenge every day. So let's see. Activities of daily living, some of what we're finding out is just that people just can't take care of themselves every day. They need resource in their home. They don't need to go to a nursing home. They need somebody to support them in their home, and they need a way for that to happen. The behavioral health care manager, Cassandra, takes referrals directly from the practices, or she takes referrals from the actual community resource specialists. And so far, these numbers are a little old at this point. She has probably well over 65 referrals so far, and she attempts to engage them, do a behavioral health assessment, and do a brief intervention, referrals, and then a lot of care coordination. So we have a patient story, just one among all of them, and I'm going to leave it to my colleagues here to tell you that story.
Good afternoon. My name is Toni Schlais. I'm the nurse care manager at Wood River Health Services in Hope Valley, Rhode Island. And the reason I'm here is just to share a story of one of our patients and the challenges that we face in a primary care setting and how the community health team has impacted those challenges and really made a change for us. Working in a primary care setting, the doctors refer patients to as many and all resources that are available, but what do you do when that's not enough? And that's where the community health team has come in for us. I'll tell a story about a patient, Jenny. She's a young woman in her 20s with a known history of sexual abuse at a young age, impulsivity, self-injurious, and risky behavior. Her behaviors are exacerbated by her during situational crises and non-existent coping skills and lack of support. She has a clinical diagnosis of depression, anxiety, PTSD, with a strong family history of behavioral health issues. She's been involved in both inpatient and outpatient psychiatric services since childhood. She has 3 small children, less than school age. She does not have a driver's license. She has to rely on someone for transportation. She doesn't have a job. She lives in subsidized housing with her estranged husband, who is the whole primary support for the family. And he just recently completed a required treatment for alcohol abuse. Jenny's applied for disability 3 times and has been denied, although she currently has legal assistance helping her to reapply. The agencies that have been involved with her and her family include DCYF, Family Care Community Partnership, North American Family Institute, Easter Seals Early Intervention, and South Shore Health Home Case Management. The patient was identified by the insurance company for high risk, high cost due to her increased emergency room and outpatient and urgent care visits, which were unnecessary ER usage because she was going there for no particular reason that they could identify. The patient had multiple calls to me. She calls the nurse care manager frequently, and although we give her guidance and support, she very rarely follows through with anything. I established a communication with the support services that were involved with her in the home so we could get the primary care physician and myself could get a better understanding of what was going on in the home that we were not privy to. That did help us gain an understanding and really get on board with what they were planning for their plan of care for her and her children. But still, she continued to go to the emergency room and the urgent care, come to the office, make appointments in the office, but had frequent no-shows. We referred her to the South County Community Health Team, resource specialists, to see if there were further supports that we were not able to identify and barriers to her care that maybe the community resource specialist was able to assist her with.
When Toni referred this patient to the community health team, our community resource specialist went out to her home to assess her needs. During the initial meeting with her, she identified that the house was, poorly kept and sparingly furnished. The community resource specialist provided Jenny and her family with clothing, furniture resources, and household items, as well as referring her to Health Source Rhode Island to reinstate her health insurance as she let it lapse. In addition to providing these resources, the community resource specialist is also working with legal services to help Jenny maintain her housing.
Still, with all of the agencies and services involved, she continued to make unnecessary ER urgent care visits and no-show appointments at the office. Now, I should also say that throughout this whole time, she had expressed to us we had done a referral to behavioral health for her. She expressed that she was receiving weekly therapy appointments in her home from this behavioral health agency. So even though attempts had been made to reach this behavioral health agency, they did not respond or interact with us at the primary care office at all. So one day, Jenny reported increased life stressors, changes in life events, and I encouraged her to reach out to the behavioral health agency. which she did. And then one Thursday morning, she called me and said that she was very anxious. She had a pending court date coming up, and she was having urges to cut. Her stress was increased by her reported inability to meet the behavioral health service. She had made several calls and left messages, but they did not return her call. I tried to reach them again, and no response. So I called the community health team, spoke to the resource specialist, and asked her to get in touch with Cassie and if the two of them could meet with that patient the same day, which they did.
So I went to the house and noticed that the patient was quickly decompensating due to the multiple stresses in her life. I provided her with crisis support to de-escalate the crisis, as well as teaching Jenny coping skills to manage her anxiety and provide education around her illness, as well as when it's appropriate to use the emergency room. The goal for Jenny is to ultimately transition her to crisis management with her established mental health provider when it's feasible. In addition to helping Jenny with her mental health issues, I'm also helping her with her legal issues. Jenny has charges against her that include a domestic assault charge, a housing eviction, and a neglect charge from DCYF that was stemmed from her domestic assault charge with a past boyfriend. I accompanied Jenny to court hearings to provide support, as well as having contact with DCYF to help facilitate the communication between Jenny and her caseworker. Currently, the community resource specialist and the nurse care manager are assisting Jenny to access Head Start and other resources for the children in collaboration with the PCP, as well as to improve the appropriate engagement with the nurse care manager and primary care practice. As in the past, Jenny has made frequent calls to the nurse care manager for assistance and multiple office visits where she was a no-show. The community health team is currently meeting with the established mental health provider and the nurse care manager to improve coordination and collaboration. The goals that we would like to accomplish with this collaboration are restarting her on her psychiatric medications to better manage her anxiety, depression, and impulsivity, as well as to develop a crisis plan that does not include unnecessary emergency department uses. So some of the successes that we've had with Jenny so far is that initially when the community health team was involved, we did lessen her ED visits to 1 in the past 3 months. Overall, her ED use has decreased, even though she has unnecessarily used the ER recently. Her legal issues have been dropped both criminally and with DCYF. The primary care practice and other agencies are able to coordinate plan of care with Jenny and are updated on her current status. As well as we were able to get her a counselor and an appointment with a psychiatrist to get her started on more psych meds. Some of the challenges we've encountered thus far with this case is that Jenny recently stopped taking one of her psych meds due to increased agitation and began frequently using the ED in crisis. Jenny's use of the ED may be a symptom of inadequate coping with normal adult responsibilities and parenting. Her housing is in jeopardy despite the community resource specialist involvement. Her transportation. As we said, Jenny doesn't drive or have a license. She has a lack of positive role models. And Jenny doesn't always necessarily follow through with the recommendations from the community health team, the nurse care manager, and the primary care physician. Lastly, there are holes in the system of care for crisis management and collaboration. The community health team is pursuing shared sessions between the mental health provider and the behavioral health care manager to address medication issues. Jenny may need more psychiatric care, more intensive monitoring, and an evaluation of psych meds. Thank you.
So I think she exemplifies a lot of what our challenges are, and I have a list of sort of successes and challenges for the program overall. But we're kind of running short on time, so I'm going to wrap it up. And know that we're staged and ready to ramp up if additional funding becomes available. And I just have to say overall that even when we have releases signed, it's really challenging to get behavioral health to kind of collaborate with you. And that's something that somehow we have to figure out how to address that barrier. Thank you.
Thank you everyone for joining us today for the presentation on the Community Health Network Wellness Program Workshop and resources to keep Rhode Island healthy. Today, some of the learning objective for this presentation is to know what the community health network is, be able to describe the benefit of referring and recruiting patient or community members to community health network programs, be able to describe the criteria to identifying people who can benefit from these programs, learn the different strategies to recruiting to programs, learn how to use a centralized referral system, learn about community health network programs available, and how community health network fits in your agency or practice. So, what is a community health network? It's a collection of community-based, evidence-based wellness program for people living or at risk for living with chronic conditions, centralized referral system for access to wellness program in support of their care. Programs consist of Department of Health and partners programs. The purpose of the Community Health Network is to provide programs to support provider care outside of the provider's office. The goals of the program is to help people improve the quality of their life and feel more in control of their health. And now I will have my partner Cindy explain how the community network helps.
Good afternoon, everyone. So, I'm here to tell you how the Community Health Network works and helps your agencies or your practices out there in the community. Thank you, Veronica. So for providers, it complements the clinical treatment, and it helps to prevent chronic conditions like type 2 diabetes, heart disease, and hypertension. For providers, it also supports the patient-centered medical home standards for providing external and internal resources for additional care management. And for community agencies, it adds more programs offered at their sites focused on living healthier. Of course, when there's the camera. All right, so I want you to meet Bob. Bob was a participant for a Living Well Rhode Island chronic pain self-management workshop. And Bob, just like every other participant that we have as part of our program, was setting an action plan one week. And everyone basically sets an action plan, so a small goal that they want to complete within the week until the group meets again, and then we talk about how successful we were in completing the action plan. And Bob's action plan, who uses a electric scooter, by the way, was to walk to the mailbox 3 times in that week. And that was his action plan, and he was sticking to it. So the following week, when everyone came back and everyone was reporting on how successful they were at completing their action plan, Bob was so disappointed to share that he was unsuccessful. So we asked Bob if he wanted to brainstorm with the group and see if we can come up with some ways to overcome the barrier. So we say, Bob, what was your barrier in being able to complete your action plan this week? And he said, well, my daughter didn't let me. She thought I was gonna get hurt. You know, I use this electric scooter. So the group asked, Bob, are you able to walk? He's like, yeah, I can walk. Hold on, let me get up, let me show you. And they were like, no. We believe you, Bob, it's okay. So the group began to brainstorm. They began to look for ideas, ways to help Bob, because he really, really wanted to walk to the mailbox 3 times during the week. So they decided to write his daughter a letter, and that's his daughter there, asking her to believe in Bob because they believed in Bob, and that Bob really wanted to complete that action plan for the week. So the following week, Bob came back on his electric scooter, of course, and he was so happy to share that he not only completed his action plan, he overexceeded and went 4 times. He went on Sunday when there wasn't even mail to go get. Okay? He also came back with a letter from his daughter thanking the class for believing in her dad, and that he was so happy to be part of the class. He's really built his self-confidence, and now she will believe in her dad. When he says, I want to try this, she will support his decision. So that's just a great example of the programs that I'm going to be talking about today that are available through the Department of Health and our partners. But before that, I can stop hitting the wrong button. I would like to tell you about Patient A. And now patient A is actually one of my newest stories, and I love this story because it's a new program that the Department of Health is offering. We've always offered it through the Greater Providence YMCA. It's the Diabetes Prevention Program. And patient A started in November of this past year, and she started at one of the hardest times you can possibly start this type of program. She started when the winter was starting. She had to go through all these holidays, Thanksgiving, Christmas, New Year's, Valentine's Day, Easter, and I found out her birthday was in there too. She also had to get through being at home with the blizzards and all the snowstorms, okay? And started the program with 203 pounds. Last I checked in April, on April 7th, she reported she was at 171, and I wish I could have been able to bring you more because I'm sure she's lost more weight now. So she lost a total of 32 pounds since starting the Department of Health's Diabetes Prevention Program. So if you ask me, I think we have something good going on here, okay? So she is still active in the program, and it's just one of our great stories that we would like to share with you so you too can believe in our programs. There we go, I figured it out. So how the Community Health Network helps? People live happier, healthier lives. They learn to manage their symptoms and medications, alleviate pain, exercise and eat properly, manage stress, solve everyday problems, communicate effectively with both their family and their healthcare providers, and overall improve self-confidence. That chronic condition isn't deciding what you're gonna do. You're in charge now. That's what we teach our participants. So some of the examples of the programs that we have available with the Community Health Network, we have partnerships with the Arthritis Foundation, so we offer the exercise program and Walk with Ease program. We have QuitWorks Rhode Island and QuitLine for tobacco cessation, and Draw a Breath with Hasbro for pediatric asthma, and also Matter of Balance. And for the Department of Health programs that we have the Certified Diabetes Outpatient Educators, the CEDOs, Healthy Lifestyles for Youth, Diabetes Prevention Program, and Living Well Rhode Island with 5 different programs, the Chronic Disease Self-Management, the Diabetes Self-Management, and Chronic Pain Self-Management, and then the 2 that are in Spanish, the Chronic Disease Self-Management and the Diabetes Self-Management. Then our partnership with the Greater Providence YMCA offers diabetes prevention, enhanced fitness, healthy lifestyles, behavioral change, and Live Strong. And there are there's additional information on all of our programs available in the packets that we have in the back of the room. So for providers that would like to use our system and refer their patients, we have this lovely little chart. And you want to identify the patients that are at risk for, have a history in their family of chronic conditions, or have a chronic condition but they're not managing it very well, want additional support, but also they have to be ready for change. They have to be ready and willing to do this type of program. So you want to refer your patient based on the health concern. Then you send it over to the Department of Health, where myself, Catherine, and Veronica will contact your patient, and you can send it through your EHR, your fax, phone, or a secure email, as long as the method is secure. And we will contact your patient and assess their needs. We're going to ask them questions on what they're ready for, what are their goals for this type of program, what they're looking to get out of the program, and then offer a program based on their needs. And then one very important key to this network is that you, as the referring provider, will receive feedback. We will close the loop for you so that you know you didn't just send this referral anywhere. No, we are active. We're getting these people the services they need and the resources. So for community agencies, if you have space within your agency and you want to host one of our programs, you would contact the Department of Health and you'd say, I'm interested in hosting one of your great programs. And then you would find appropriate space within your agency based on the guidelines that we provide you. You want to set a date maybe 4 to 5 weeks out to run the program, and then post posters and sign-up sheets for your members within your agency to see that they can sign up for this program. And also, we can post it on the Department of Health website so that people in the public can also see it as well. So for providers, again, after a patient completes the program, we will send feedback to you. You can keep this information in the patient's record, just kind of to touch base with them and ask them how, you know, they did, what they felt about the program. And I mean, that in itself can give you an idea of how the programs work so that you can refer more in the future. And then ask your patients how their self-management skills can help you together manage your condition. You guys are a team. Let's get them, you know, healthier. You can also refer patients, you want to refer patients with chronic conditions. Again, at risk, family history for a chronic condition. Those people that are at a loss of self-confidence, they only see what they can't do anymore. Refer patients who have trouble following through with the recommended lifestyle changes like weight loss and exercise. But something very important is that provider cueing is key. They believe what their providers are telling them. They will listen to you. Again, I can't emphasize it anymore. Provider recommendations are so essential. You want to run EHR reports to identify patients with or at risk for chronic diseases. Utilize your patient's portal. They are looking now to see what communication you're sending out there. Put our information out there and let's see if we can get the word out about our programs. Post the program information and recruitment materials in your waiting areas as well. And invite us, your program representatives, to your events where your patients gather so that we can tell them firsthand the experience of going through one of our programs. This is the referral form that providers can use to refer their patients. You would fill out the top part with the patient's name and then your referring provider name as well. You would check off any patient health concerns, either the ones they want to work on or the ones you've discussed with them that they want to program for. Any one of the conditions listed in the box do require a provider signature because it's kind of like seeing a specialist. And then if you have a program request specifically that you've discussed with the patient, you can just write that in that line there. You want to have your patient complete this authorization form because if they decide to go to a partner program, the Department of Health cannot share that unless they've authorized. And that's what this sheet here covers. It gives the Department of Health, the patient navigators, authorization to go ahead and get them enrolled into that partner program like the YMCA and the Arthritis Foundation. For my community partners out there, if you want to recruit people, I would say post posters, sign-up sheets with dates for the program throughout your agency. Have a designated person to keep track of the recruitment and connect with the Department of Health so that we're all on the same page. And have brochures accessible for your members. As well as post on your community sites. Some of your sites, agencies have websites. If you have websites, I would recommend putting our information on your site so that people can view it. Invite representatives to your agencies when you have community events. And these people that are part of your agencies, they're there because they trust you. So put the word out there so that they too can be part of another great program that's available for them. Let us be partners and get our programs into your agencies so there's something more that you offer. So just to kind of wrap up, some key points about the Community Health Network. It's one centralized location to find wellness programs to support wellness. There is a calendar of programs available on the Department of Health website. It's on the chronic conditions page. And we have patient navigators available in Spanish, Creole, and Portuguese. For more information, please visit our site. We have our forms and more information, as well as a link to order brochures for your agencies. And please feel free to contact us anytime for us to come to your individual sites. We're more than happy to join you. Thank you so much.
Thank you, everyone. So my name is Alicia Klein. I'm one of the medical directors at the Department of Health, and Donna Goldman and I had organized this breakout session when we were thinking about what a session around healthcare system issues for addressing health disparities and health inequities might look like. We wanted to drive home the message that we need to know where we're beginning and where are the disparities in our state right now. And then we also wanted to show some examples of how we can start to think innovatively within our healthcare system and move beyond the traditional exam room, doctor-patient, getting instructions, and really talk about the importance of having community-based resources and individualized community available resources to meet people where they are, improve access, and make things fun and acceptable so we can activate individuals and communities to really think about their health. So I really want to thank all the panelists for the time they put in to putting together these presentations. It was really interesting, and we have time left over for people to make comments, ask questions, react, respond. So I'd welcome any comments from you all at this point.
I'm close to the South County project. I assume one of your endpoints is, as you already mentioned, decreasing frequency of ER utilization. And I assume you can document it, decreasing hospitalizations. But are there any intermediate endpoints
That we're
see as
looking at?
goals?
Yeah. So, I mean, we certainly develop care plans, and in those care plans, there's interventions, based on the problems that someone has identified with their community resource specialist. And then we evaluate how successful we are in trying to alleviate whatever those problems are. So we're collecting that kind of information. That's patient-level problem intervention type. But we also get feedback from the health plans at how it's sort of doing overall. They're sort of tracking the intervention group, even though there's going to be an external program eval that's done by someone else. The health plans themselves are giving us feedback at an aggregate level on whether these utilization is decreasing or not, and whether the total cost of care for that group is changing. So I don't know if you have other suggestions about what we might be.
I mean, you have an example that isn't as frustrating as the
Yes,
you talk
we
about?
have a terrific example, of someone who we identified a man who had worked for years, and he recently lost his job probably 2 or 3 years ago, and he had been an active member of the community, owns his own home, lives there with his wife, and through the lack of not working, as well as some moderate medical problems, it's all kind of escalated him to being significantly medically impaired at this point in time. But he had identified that he wanted to quit drinking as one of his goals, and that was certainly contributing to his obesity and other issues. And at this point in time, he's abstinent. And he started to lose weight, and Cassandra's done a lot of work with him as the community resource specialists have also helped him to claim bankruptcy, to try to really get their finances under control, and to really make some constructive changes for himself in terms of how he utilizes his primary care appointments. And he's become a more effective user of health care, as well as starting to really address some of his own medical issues. So a terrific success story so far. We have those as well.
Many. Yes, you had a question?
Yes, I think it's Ms. Ariza. Can you be more specific to host our program? Like, what's the protocol? And is it like all those programs, or you go and talk about like every all of them, all the programs that you cover? How do you go about it?
So her question was to bring our programs out to the agency. Is it all of the programs, or is it like what is the protocol for bringing our programs out to community agencies? If you have a specific program that you're interested in, we can certainly come and speak to you, or advertise that particular program. We come out to events with packets, kind of like what we have in the back there, to give the program guide and a selection of programs to the community. I would recommend as a community agency to look at the guide, and if there's any particular program of interest, then you can contact us. My information's everywhere on that form, and I can give you my card directly as well. And you can contact me directly, and then we can coordinate and bring whatever program you're interested in to your site.
How about financial and immigration status? That matters?
No, it does not.
Yes, question in the back.
In terms of the South County program, have you identified motivations and benefits from a client perspective as far as increasing use of emergency rooms?
Motivations and benefits.
So maybe asking about what the patient experience as one of the kind of.
Has anything come out in terms of something that could be helpful generalizing? We understand why from, health plans and health providers, we want to decrease it. But in terms of client perspective, has there anything that, has anything come out that we can generalize as far as,
What they-
point out to other populations?
Well,
Helpful about this or beneficial to clients?
Okay, so if I think I understand what you're asking, I mean, they sort of articulate oftentimes that they don't know how to utilize the system at all. They lose their insurance, they don't even know they've lost it. There's so many things on a daily basis that they just don't know how to access whatever resource might be there. Most often, they're identifying the goals that they want to work on, and they don't even know some things are possible. And so the community resource specialists are great at sort of saying, well, we can help you pay down some of that debt. There's this program over here or whatever, and they don't know anything about it. And they are very appreciative. But I think one of the biggest challenges is how fractured our system is in terms of, we sometimes will call DHS and we'll get one piece of information on a patient and call someplace else and it's a totally different piece. And meanwhile, the person has no insurance and they get kicked out of the nursing home and it's like, you can't even make this stuff up. So there's a lot of fracture out there. Does that address your question, kinda?
It sounds like you're saying that they don't even know that there are alternatives.
Oftentimes, they have no idea what resources are out there. And they identify the lack of knowledge oftentimes as they don't know how to help themselves.
Yeah. And I would say as far as the emergency room use and the urgent care use, they just don't see any difference with going to the emergency room or going to the primary care office. They really just don't see that that is a problem. So that is something that you have to educate a lot of the patients on, because they can go to the emergency room, it's closer, and they can go whenever they want. They don't need an appointment.
Yeah. And it's teaching them that actually if they go to their primary care office, that there's going to be some continuity in their health and health care that they never realized. Some folks didn't even have insurance, so they weren't even accessing services before.
Two questions. So the first for the DOH programs. What is the strategy that you guys have been getting into private and primary care offices, and not even just primary care, other subspecialties like physiatry and other people that treat chronic pain, because this is becoming a huge problem. It's becoming a multi-million, billion-dollar industry treating chronic pain. So I'm sure if more physicians were aware of these programs, like how do you see yourselves navigating that, or is this just a word-by-word situation?
So her question was how we get out to different types of providers, whether it's primary care doctors or providers of different types. We are open to going, this is a network that started about 2 years ago, and we're growing. We're looking to expand and get the word out. I think we've used the Department of Health, like an email system to get out to providers. You see us occasionally, maybe on the radio. There's different methods that we are trying to get the word out there, but really on the site, and there's Donna.
What we've been doing is we work with many groups, many physician groups. So we've worked with the care Thank you. Besides chronic pain, we are in the Medicaid waiver for the opiate group, and so we are actually reimbursed for these programs for the chronic pain and the chronic disease self-management in that group. But as Cindy said, we're ramping up, so there's enough product, which means programs, and they're located in places that are accessible. And as it relates to, I just want to mention, as it relates to what we're doing as far as disparities, the health equity zones, as you know, are our big investment in the community, and so we are ensuring that we are locating near the health equity zones. We're locating near the federally qualified health centers. We're locating near the patient-centered medical home. In addition, we are outreaching, and we'll be increasing in that to practices that may be not part of this bigger issue of patient-centered medical homes. So these smaller practices that are out there and some of the specialty practices, we'll be working directly with them on projects and getting the information out. And we look to you that if you have some suggestions for, we do have patient navigators that can go out, as well as nurses, and myself included, to meet with various groups like nurse care managers or any kind of group that's interested. We'll be happy to do that.
Thank you. I just wanted to, because I'm going into physiatry. That's my field I've chosen. I'm a medical student, so
Great.
I see a lot of this chronic pain.
Yes.
And it's very important. Thank you. My second question is for Ms. Rawlings. What are the next steps for the commission?
Thank you, Amber. Our next steps for the commission is working on their strategic plan. So the first 2 years was basically to get this legislative report out. That took a lot of time, a lot of energy, and a lot of mobilization, with also a lot of challenges in terms of data collection. I think I mentioned probably in the first part. Now in the second part, that one of the biggest challenges was, not having a streamlined data collection system to measure social determinants of health and social, factors that impact health. So as we move forth, we are looking to the implementation of the recommendations that we have, strategically partnering with other organizations, other CBOs, faith-based organizations, what have you, to go ahead and work together so that we can kind of get this policy and drive it forward. Because we don't have any policies necessarily in place that we're working on, but there's a lot of things that a lot of the other organizations are doing that we can help push along to try to get our agenda also, reached as well. So it's going to be with collaborating with community partners. There's going to be a lot of education with health and all policies and trying to get, getting all of the state agencies to understand that, every aspect of health and every aspect of your lives is health. So, understanding that education is health policy, understanding that, where you live, healthy homes is health policy, understanding, traffic, the roads, DOT, everything like that is health policy. So there's going to be a lot of education that's going to be going on with the communities as we go further into the communities as well, to have community forums to to get a better understanding of what is it that people need and what is it that we need to address. So we're really trying to get more community voices. Some people might be aware we did go out to Macaulay Village, Dorcas International, a few other community-based organizations to really hear the voice of the people and find out what we can do, what is needed, so that we can kind of bring that to fruition and work together. With that being said, the main thing that we're working on, like I said, is our strategic plan, and really trying to grab our community voices, but also of the providers, the people at the table, and really make sure that the sustainability is there. The sustainability is there, the people, the right people are there. One of the things with the commission is it's by statutory. It is open to, community members. So community members are welcome with their ideas, thoughts, ideas about everything to help move that forth. So we have a community engagement team that, goes out into the community. We have our data team that focuses on collecting the data. And like I said, that's a huge That's a big thing, because some of the information in our legislative report we weren't able to capture. So for example, our Southeast Asian population, we weren't really able to capture a lot of information on that population based on the way that it's measured. And without having a streamlined measuring process in terms of collecting data, it makes it harder. Another population that we weren't able to completely identify and address was the Native Americans. We're all well aware that there's plentiful Native Americans in Rhode Island, but with the numbers, that still was a challenge for us. So it's pushing forth the agenda, pushing forth our recommendations, and pushing forth with our strategic plan.